Professor of Ophthalmology based at the Centre for Eye Research Australia and the University of Tasmania. In the next session, we actually have two presentations. The first presentation is from Professor Graham Lee, who is Professor of Ophthalmology and co-founder of the International Ophthalmology Portal. He will be presenting on a trabeculectomy technique update. The second presentation is from Professor Robert Casson, who is Professor of Ophthalmology at the University of Adelaide, and he will be presenting the Gillies lecture that he presented at this year's Australian New Zealand Glaucoma Society talk. The title of this presentation is Glaucoma Challenges for the 21st Century.
Okay, thank you for asking me to do this presentation. What do you do? So this is about trabeculectomy, and it's the tips and tricks of the Australian New Zealand Glaucoma Society surgeons. I'm Professor Graham Lee. I'm from Brisbane, Australia. So I'd like to acknowledge my co-authors, Dr. Lance Liu, Professor Rob Casson, Professor Helen Dinesh Mayer, Professor Peter Shah, and also the members of the Australian New Zealand Glaucoma Society Consensus Group. And this is a consensus that we formed in February this year, so just recently, and this is a list of all the different members. So trabeculectomy has come a long way since Cairns published it in 1968, and you can see here that originally the conjunctival flap was limbal based, but the scleral flap was fornix based, and that's quite different to the technique that we use now. A major influence has been the Moorfields safer surgery system for trabeculectomy, and this has evolved over a number of years, since about 20 years ago or so by Sir Professor Pencore at Moorfields Eye Hospital. And the idea is to get a large posteriorly draining bleb, and the conjunctiva is normal, so it resists blebitis and any thinning, and it's supposed to have a long-term drainage life. So what we did was we surveyed 49 of our glaucoma specialists, and these are all experienced trabeculectomy surgeons. And we did this over a virtual Australian New Zealand Glaucoma Society meeting on Zoom. And we were able to use the online polling software within the Zoom to do the survey. And basically, we wanted our participants to look at what they would do for a routine trabeculectomy for primary open angle glaucoma. So no complicated cases. So what were the results? Most of our surgeons didn't pre-treat before trabeculectomy, but the ones who did used either topical steroids or possibly topical pilocarpine. By far, most surgeons were using day surgery, although there were some surgeons who were using a combination of day surgery and or overnight admission. And something that really has changed over the last 20 years or so is the use of monitored local anaesthetic. There are some surgeons who still routinely do general anaesthesia, but there's a minority. And of course, we still use general anaesthesia for patients who are uncooperative or possibly pediatric type patients. So there are a few techniques that the surgeons were using that had over 90% consistency. And corneal traction suture was very popular, 94%, and this was using a 7/0 Vicryl or sometimes silk. And this supersedes the superior rectus suture that was used previously that often caused subconjunctival hemorrhage. The fornix-based flap was also widely used, and this is an illustration of using Westcott scissors and atraumatic forceps to dissect either side of the superior rectus and over the checked ligament. And this also supersedes the limbal-based flap that often causes a ring of steel effect, the fibrosis limiting the bleb flow. So with the mitomycin, a lot of our surgeons are using this almost universally, and this is a big change from, say, 20 years ago when people were using more 5FU. and this often caused thin cystic blebs and quite localized. And before that, trabeculectomy didn't use any antimetabolites, and as we know, this caused scarring, and the scleral flap would stick down. So yeah, mitomycin is almost universally used, and there's various ways of applying the mitomycin, and this technique being shown here is pledgets, and the pledgets are often PVA. So PVA, the idea is not to cause any fragmentation like with a methyl cellulose type sponge. And the various other techniques are things like the corneal protection shields that are PVA, and these are also quite useful. You put in, say, cut in half and you get a hemisphere. This is a conjunctival retraction device that I've created, and this atraumatically retracts the conjunctiva, and you can place the pledgets either side of the superior rectus and also just behind the retractor there. I like to also use a pledget under the scleral flap, and this helps reduce fibrosis around the scleral flap. The peripheral iridectomy was often done in 98% of cases in phakic eyes, but not quite as commonly done in all cases in pseudophakic eyes. So I tend to judge it if the anterior chamber shallows and the iris comes towards the sclerostomy, I will do the peripheral iridectomy. But especially in pseudophakic eyes, if the iris is staying back, I'll avoid iridectomy to reduce the risk of bleeding. So they're the more commonly used techniques. How about variations in the technique? This is an Ong speculum that was used by some of our surgeons, and you can see this is designed so that the lower blade is larger, and this introducts the eye. And the idea is that you can avoid the use of the traction suture. The surgeons who used this speculum said that in some cases it may not always sufficiently introduce the eye, and that's when you still need something like a traction suture. The scleral flap formation was also very variable, and surgeons use a combination. This is a calibrated diamond knife, and you can cut down whatever depth you like, 300, 350, 400. And also the use of a crescent blade to dissect the scleral flap forwards, and the use of a diamond knife to cut the sides of the flap, and the idea is not to cut the sides too close to the limbus, and this is to avoid anterior flow. And what I find is if you do the scleral flap at 12 o'clock, you often get this collected channel that needs to be cauterized, and this is to avoid post-operative bleeding. Scleral flap shape, it was also quite variable. A lot of surgeons were using the rectangular flap, about 70%. Some surgeons use a trapezoidal flap, about 10%, and some even use a square flap, that was 9%. And these varied in sizes, most commonly 3 by 4 millimeters, sometimes 3 by 4 by 5 millimeters, with the 5 millimeter at the limbus. And some surgeons even use a larger flap, like 5 by 5 millimeters, and this was to give you a more diffuse drainage. The most popular thickness is half thickness, and this is about 400 microns, which is about half the thickness of the sclera, which is about 800 microns at the limbus. With the mitomycin, there was also a number of different techniques to apply it, and most commonly a pledget was used soaked with the mitomycin, and these are PVA sponges, and this is to avoid the fragments you might get with methyl cellulose. Some surgeons chose to inject it under the tenons, and this gives you a nice diffuse mitomycin application, but the problem is it can be a little bit difficult to control where it goes, and also to stop it getting at the limbal tissues. Commonly it was 0.02, 0.03% concentration, and this is in a routine trabeculectomy. If you have thinner tenons, you might want to reduce it to 0.01. And there's also other surgeons that use 0.04, sometimes 0.05%, and this is for the thicker tenons like you see in Asians or African Caribbeans. The times are usually 2 to 3 minutes, and this again can be varied according to the state of the tissues. And in terms of putting it under the flap, this is used by some surgeons to stop the fibrosis around the flap, and I find that this is where a lot of the long-term failures actually occur, sticking the scleral flap down. So pre-placed scleral sutures are one of Sir Peng Kaur's introductory techniques to reduce the amount of hypotony time after your sclerostomy. And you can see here that this is one technique where you leave a loop, and you can do a triple throw, quadruple throw, or some people use a quintuple throw of the loop. And the loop can be recovered post-surgery to improve the flow through the scleral flap. The Kelly punch was the most common instrument to do the sclerostomy, and also the core punch was very often used. The difference between the core punch and the Kelly punch is the core punch is 0.5 millimeter, as opposed to the Kelly punch is 1 millimeter. So usually I would do, say, 1.5 Kelly punches or 3 core punches, and this gives you about a 1.5 sclerostomy. Peripheral iridectomy was variable in its technique, and you really don't want a long radial iridectomy, because this can cause uniocular diplopia post-op. You want a smaller iridectomy, about 1 to 2 millimeters, a little bit broader base at the limbus. And the way to do this, I can show you on this video, is to use a tooth colibri to grab the peripheral iris base, and you cut the iris using a Vanna scissors, and you cut tangentially. And the idea is you can see darker pigment when you get a full thickness iridectomy, and this gives you a nicely formed iridectomy. Surgeons often test the flow after putting the sutures in, and I find this very useful because sometimes your anterior chamber, say, is not formed, and you may need to put more pre-placed sutures, or some surgeons use interrupted sutures or adjustable sutures. Conjunctival closure was a very variable part of the technique, and I tend to use 2 purse string sutures at the edges of the wound and do 3 buried horizontal mattress along the limbus. Other surgeons used wing sutures either side, or some surgeons even use 1 horizontal mattress across the limbus. But the main thing is to get a watertight seal at the end. And the idea is to use 10-0 nylon to reduce the inflammation from the sutures. But some surgeons were using Vicryl, and this is a dissolving suture. At the end of the case, you can do a Seidel test, and this is to test for any leaks at the limbal wound, and also to make sure you don't have any buttonholes, because any leaks at the end of the case, you know, make sure they're repaired before you see them the next day. As we all know, post-operative care is very important. It's over half the whole procedure of the trabeculectomy, and many surgeons use topical antibiotic and topical steroid. Only about 40% of surgeons use atropine, and the idea is to dilate the pupil and deepen the anterior chamber. Most surgeons were seeing their patients 3 to 4 times in that first month, and topical steroids were continued 3 to 6 months, and it does depend on the post-operative course, depending on the amount of inflammation. Some surgeons use routine 5-FU, about a third, but this is mostly necessary, I find, if you're seeing fibrosis or seeing a tenon cyst formation. So this is the sort of results you like to see. This is a patient I saw recently. So this is a patient 7 to 8 years down the track. She's got a nicely posteriorly draining bleb. You can see the conjunctiva is healthy and there's no areas of thin or cystic change. And she's got a pressure of 8 on no medication, so very good result. So in conclusion, There's certainly a wide range of techniques for trabeculectomy, and there are some consistent techniques, and this is to give you optimal patient outcomes. And hopefully this report will help assist surgeons into what surgical techniques they want to try and incorporate it into their best practice. Thank you.
Thanks very much indeed for inviting me to present at the World Glaucoma E-Congress. It's a great pleasure to be with you here in cyberspace and representing the Australian New Zealand Glaucoma Society. So I thought I'd take this opportunity to present 10 challenges, as I see it, that we face in glaucoma in the 21st century. So the first such challenge is that of the ageing population. This is perhaps the greatest challenge, and our overarching aim, of course, is to maintain healthy eyes for life, but this is becoming increasingly difficult as our patients and the population in general live longer and longer. In terms of the growth rate, the global population growth rate peaked in around 1968, but in terms of absolute numbers, we're on the steepest part of the climb now, really with no respite in sight until well into the next century, where the global population is expected to peak at around 11 billion. So what were once ageing pyramids have now become ageing towers, and particularly prominent manifestation in some regions, including China. So this is a big problem in many regions of the world. And as I see it, the answer probably lies not so much in health reform, but more in economic and political reform. And perhaps to the extent recognising that in certain regions with a fiat currency like Australia and UK and United States, that taxes actually don't fund federal government spending. Challenge two is that of determining how prevalent is glaucoma. So we have plenty of data on that, don't we? Well, the number of people globally is expected to increase over time with glaucoma, of course, and this is particularly the case in Asia, partly because they have large populations and also because they have a large prevalence of angle closure glaucoma as well as open angle glaucoma. Trends in numbers of people blind from glaucoma are disturbing and have an exponential type trend paralleling that of the ageing population. But there are problems with these estimates and meta-analyses. They derive from surprisingly few original sources with many large geographic gaps, particularly in Africa, and much of the data is derived from RABs. And importantly, they nearly always take virtually no account of blindness due to field loss. So the recommendations here are to empower local teams to conduct epidemiological surveys, to utilise new technology such as iPad visual field tests in ophthalmic surveys, and potentially to provide support from a dedicated professional glaucoma epidemiological team, perhaps something like the field operative division of the Vision Loss Expert Group. Challenge three is to obtain better estimates of the lifetime risk of glaucoma-related visual impairment. This paper from Peters and others published in AJO 2013 is widely cited and often appears in grant applications, perhaps because it displays the worst, as far as I'm aware, risk of blindness throughout lifetime of glaucoma at around 15%. Other papers report lower figures, but really we don't have a good handle on this. But it should be possible to obtain through modern digital technology a much sharper estimate of the true risk to vision over lifetime. And this could be enabled by a synthesis of Forum-Humphrey data at an international level, for instance, of de-identified data. Challenge four is that of detecting glaucoma, and there are two elements here. The first element is that of finding glaucoma. The Blue Mountains eye study from Australia was a landmark study that reported a number of important findings, including a 50% rate of undiagnosed glaucoma. Now, that figure was also recognised in a number of other similar studies, but the sobering news is that even in a very recent study from Australia, the Australian National Eye Health Survey, the prevalence of undiagnosed glaucoma was still 50%. So we haven't made a lot of inroads into that problem. Currently in high-income regions, we find new cases essentially by opportunistic detection, with the optometrist doing the heavy lifting here. Is it possible to be more strategic around this? Is it possible to have a population-based screening glaucoma? Well, potentially, but it currently comes at really quite a price, and that is that our instruments have too high a false positive rate. So we still do not have an ideal method for screening at a population level. The second element of glaucoma detection is that of measuring change over time once diagnosed. So before the problem of longitude, as it was called, was solved by John Harrison and his clocks, ships navigated by a method known as dead reckoning at sea, whereby sailors would throw these chip logs overboard and count the number of knots in the rope that passed through their hands over a certain time period. Now, to some extent in glaucoma, we have our own problem of longitude. We're measuring velocity of glaucoma by dead reckoning. We're trying to determine where we are along the disease spectrum and how fast we are travelling. The current tools are not bad, but there's room for considerable improvement and much greater detail at a more fine-grained level. So the current paradigm requires actual loss of tissue or gross changes to age-standardised function before change is detected, and a new paradigm would see a much greater responsiveness with better prediction and real-time measurements. So the recommendations are to at least optimise opportunistic detection, the training of optometrists in low-income regions, being aware of emerging technology and deliberate interdisciplinary collaboration, and the adoption of emerging technology into glaucoma research and into our clinics. Challenge 5 is that of understanding the risk factors for progression. Now, we've made enormous advances in our understanding of glaucoma genetics over the past few decades, in no small measure to groundbreaking work from Australian researchers. An important advance in clinical practice has been personalised medicine and is the idea of a polygenic risk score, which attributes a risk to polygenic diseases like glaucoma based on a weighted sum of the known gene variants in the patient's DNA. And we can combine this polygenic risk score with other potential risk factors, as has been done in the Progressor study from Australia, led by Jamie Craig and involving a number of glaucoma researchers throughout Australia. And these are finding their way into routine glaucoma practice. But challenges remain. We need more genetic data from non-European populations, and there's also room for improvement in the mathematical modelling. So we can foster polygenic risk score production in collaboration with Asian colleagues. We can rethink the mathematical modelling. I'm certainly not the first to suggest this, but it seems a ripe area of productive research, especially since any such modelling can easily be back-tested on existing data. It also seems to me that machine learning would be extremely valuable here, such that without necessarily hypothesising any particular mathematical model, an artificial neural network could simply be trained to recognise those at risk of progressing based on their DNA code. Challenge 6 is that of understanding glaucoma pathogenesis, which still remains very poorly understood. This paper from 40 years ago from Harry Quigley and others, in my opinion, is still one of the best in the entire glaucoma literature, with the authors concluding that the site of damage to the nerve fibres was the scleral lamina fibrosa, where there was a local blockage of axonal transport. Glenn Chidlow, a senior scientist from my own group, revisited this and reinvented the wheel to some extent, but in investigating this phenomenon in rodent models of glaucoma, demonstrated quite marked anterograde axonal transport blockage, consistent with those findings from primates and humans, so that was reassuring. The recommendations here are essentially more study on basic pathology in human glaucoma and potentially the establishment of a national or international tissue bank of glaucomatous eyes. Challenge 7 is that of managing glaucoma in low-income countries. So it's hard enough in high-income countries, but becomes a particularly vexing problem in low-income regions. How do we capture undiagnosed glaucoma? Is monitoring even possible? What is the best management option? All difficult questions, but a critical starting point is to provide a well-trained glaucoma workforce. To that end, I'm very proud to be part of the Sight for All glaucoma visionary team. Sight for All is a NGO based in Australia. Many ophthalmologists in Australia and New Zealand do excellent work with Sight for All. I'm very proud to be part of the glaucoma team. Challenge 8 is that of understanding how glaucoma affects quality of life. And I must confess that it's only recently that I paid more attention to this problem. I've been focused more on preserving retinal ganglion cells, and as eye doctors, we tend to focus on preservation of vision. We've seen this sort of plot before where we have retinal ganglion cells versus time. And in untreated glaucoma, we have a certain rate of neurodegeneration that may result in an unacceptable visual loss before end of life. Perhaps something like that would be a bad outcome. And for a chronic disease, neuroprotection can be defined as a reduction in the rate of neurodegeneration. And so we attempt to preserve vision for the patient's entire life. So we might detect the glaucoma and manage to hold off unacceptable visual loss before end of life. But this is becoming increasingly difficult as patients live longer, and ideally we would have earlier diagnosis and more pronounced neuroprotection extending well into old age. In addition to the neurodegeneration function of the retinal ganglion cells against time, we might also consider the function of quality of life against time. So that's likely to have a more complex pattern and highly individualized, perhaps something like this, whereby we might have a glaucoma diagnosis and in itself reducing the quality of life in conjunction with topical therapy with perhaps some side effects. We change the topical therapy, there's an improvement in quality of life, perhaps some more problems and side effects. We perform an SLT and quality of life improves, but we're still progressing. We conduct some surgery and that all goes well. The patient's happy. Quality of life is improved. They're off topical medication, but there's still some progression. Surgery starts to fail. We perform more surgery sometime later. This one doesn't go so well. There's complications. Quality of life is impaired. And eventually, visual field continues to deteriorate until there's loss of driving vision and the quality of life falls off a cliff. So that would all be highly individualized for each patient, and essentially we would be aiming to optimize, to maximize the area under the curve. And the recommendation here is development of research and clinical tools to assist us with measuring the quality of life in glaucoma. Challenge 9 is that of new treatments, and we still only have one treatment for glaucoma, and that's IOP reduction. Has MIGS been an advance? I personally think they have, and I think the concept is certainly an advance worth pursuing, although admittedly the IOP lowering effects are not particularly overwhelming, but the reduction in topical medication is an important outcome in terms of quality of life. My own particular interest is that of neuroprotection, and it's not really even the holy grail, is it? That would be neuroregeneration, but neuroprotection itself is proving a tough nut to crack. My own group is particularly interested in bioenergetics, and our idea underlying this is that the retinal ganglion cells are particularly vulnerable to energy insufficiency. We came at this initially with the idea with the vitreous acting as a potential reservoir for energy substrates. We identified that glucose in protected retinal ganglion cells in experimental glaucoma and temporarily recovered vision in primary open-angle glaucoma. This was an exciting paper published by Pete Williams and others in Science in 2017, and I was delighted to have the opportunity to collaborate with Pete and Simon John and others on a project investigating another potential bioenergetic agent, pyruvate. Chelsea Geimer, a student from our lab, demonstrating that pyruvate protected retinal ganglion cells in our rat model of glaucoma and their axons. So this is a potential, another agent that could be easily clinically translated. Flora Huey, as lead author from Jonathan Croston's group, identified a really important finding that vitamin B3 provided electrophysiological neurorecovery of retinal ganglion cells. So that's really highly motivating for a B3 clinical trial. So the recommendation here is essentially international collaboration on multi-centre clinical trials running in parallel to get some treatments to our patients. Finally, the final challenge is that of the elephant in the room, which is the funding. How are we going to pay for all of this? Well, I think that we need to recognise that no one's coming to help get us down off the mountain here, that we need to somehow figure this out for ourselves. But my feeling is that we have a lot of smart, skillful and motivated people in glaucoma research, and that these human resources can put their minds to IP generation in a self-reinforcing system to continue outstanding glaucoma research around the world. Thank you very much for your attention.
Thank you very much for a great two talks, Graham and Bob. I am, as you can see, alone today. But that's okay.
You're not alone, Lydia. You're with friends.
I'd like to thank everyone for attending our session. First, let's start with Graham. Graham, there's been a lot of activity in the questions panel for you, but just a question from me. You know, you said you don't make the side cuts all the way to the limbus. How far do you make it from the limbus to prevent that anterior flow?
Yeah, the traditional teaching was all the way to the limbus into cornea, and that gave you potentially anterior flow and really want posterior directed flow. The thing is, if you don't make your incision all the way to the limbus, it can be more difficult to lift your flap to do the iridectomy. So that there is a compromise there. You want to probably still be in sclera, but just behind the limbus and enough to be able to lift your flap. The problem is when you lift your flap and you have that folded flap over your sclerostomy, that can actually block your sclerostomy, I find. So yeah, you like to have that hinge of that scleral flap so you can actually still see the sclerostomy.
Do you ever vary it depending on the elasticity of the sclera?
Yeah, in young people that they have very elastic sclera, and it can be very difficult to close. And on those patients, you might like to keep the flap even a bit bigger, a little bit thicker, and often you need more of those. You can do releasables or interrupteds, but you often need more, I find, in the younger patients with the more elastic sclera, for sure.
Now with it says with the pilocarpine, not everyone uses pilocarpine, but do you use pilocarpine?
I don't normally do, actually, Rydia. Sometimes with the block, you have adrenaline in the block, and that dilates the pupil. And when you have a dilated pupil, if you have to do the iridectomy, the iridectomy often ends up too large.
Yeah,
so
like that long.
Sometimes I have to put an intracameral mycol or something like that to shrink the pupil. But most of the time, I don't routinely do pilocarpine.
Yeah. What about, I noticed that the injection rate was about 17% of mitomycin, which is actually it's a lot higher than the recent British and American survey. So that was quite interesting, I thought. Of all the questions, was there any really surprising results for you, or was it pretty much what expected?
I think the beauty about doing these surveys is that you get to know what other people do, and I don't think you can be too rigid in your technique. You always think that your technique is the only way to do it because that's how you learnt it. But the survey opens your eyes up to new techniques, and even just talking with you guys, you learn different tips. Like I really wouldn't mind trying that Ong speculum. That looks like it could be a goer. Sometimes the traction suture can be a bit difficult, especially if your cornea is a bit thin, and it can cut out sometimes, and that can be disruptive.
In Sydney, we have a large Asian population. So, do you vary your technique for these Asian eyes?
Yeah, I got quite a number of Asian eyes. As you know, a lot of them, they have narrow angles too, and I actually prefer to operate on these patients once they're pseudophakic. So yeah, you can do the cataract first if you have that luxury, and then do the trabeculectomy at least 6 to 12 months later. If you have to do combined, well, you do combined, but I just don't like to see aqueous misdirection. That's always, in the back of my mind when I'm doing trabs in narrow angles, that there's always that potential for aqueous misdirection post-op.
Bob, do you have any comments about Graham's talk while I have a little read of the questions?
Oh, well, great talk. Thanks, Graham. I must admit that I'm a massive fan of the Ong speculum, so I use that routinely, and I get really annoyed if I can't use it. So I would find it successful in maybe 90% of of cases, so providing sufficient access.
Okay, so Graham, do you? I'll just ask some questions. Do you identify the tenon layer and suture it to the sclera before conjunctival closure suture?
Yeah, that is absolutely critical. So yeah, that's a great comment, because sometimes if you don't incorporate the tenons and the conj into that limbal repair, you get post-operatively down the track, you get those thin areas along the limbus, and they're really annoying, and potentially they can become like a almost like a blowhole type thing. So yeah, you definitely want to get that tenons down and incorporate it into that wound. Yeah, it's a good point.
The next question is, how do you choose patients who you would not do an iridectomy?
Yeah.
Bob, do you do an iridectomy all the time or some of the time?
I pretty much do an iridectomy all the time, really, although I know a lot of people don't, you know, fakes or some other cases, but I routinely do one.
I must say,
Yeah.
I routinely do it too. But
yeah,
Graham,
it's again, you know, some of our training, you know, we've had it drummed into us that you have to do iridectomy, but it's times when, like someone mentioned, a myo with a deep anterior chamber and, you know, potential for possibly vitreous loss and disruption of the vitreous base and potential for tears and detachment, and they could be on anticoagulant as well. And in those sort of cases, if the iris is sitting well back, you know, you don't always have to do that iridectomy, I think.
Yeah, well,
yeah,
there's quite a few questions on iridectomies here.
it's controversial, the iridectomy.
There's certainly quite a few. Now, Bob, I think we'll move to, thank you for your fantastic talk. I mean, I think there are really major challenges that we have, and you know, you've given us a few tips about what we can do about them. But if you were like an ophthalmologist starting out right now, wanting to be a clinician scientist, which question do you think they should try to answer? What would you do now if you were 20 years younger?
That's a good one, Rydia. Well, I think some of the, you know, emerging technology around AI is particularly exciting with application to glaucoma. It's hard to nail it down to one thing, I think, Rydia. I mean, there's a lot of big questions still. There's still the problem that the only treatment we have is lowering the intraocular pressure. So there's got to be some other method apart from that. So there's still the whole field of neuroprotection to explore. Genetics, of course, earlier diagnosis, lots of things to do. So, I mean, it's an exciting field, always an exciting field to enter.
It feels like there is just as many questions now than as there was when we started, Bob.
Yeah,